Good morning, doctors and participants of this edition of the Hindu Wellness Series presented by the Kauvery Hospital, Chennai. The topic for today's webinar is changes in the scenario of heart attack management. September 29th is World Heart Day, and it is crucial that we all take a pause and understand how we can keep our heart healthy. According to doctors, the awareness of cardiovascular health and diseases is still low and poor among our population. We are often left shocked by the news of sudden death of people who otherwise seem to be healthy and fit. There have been too many recent cases of heart attacks and cardiac deaths in celebrities, as we all know, from singer KK to actors Siddharth Shukla and Puneet Rajkumar, to mention a few, all of whom were young and seemingly fit. And these deaths, among many others, have sparked a lot of concern. So today's topic is an important chosen one for discussion, as we need to understand how to manage a heart attack in different situations and the changing scenarios of our eating and living lifestyles today. Joining us today would be two accomplished doctors from Kauvery Hospital. I have the pleasure of first introducing Dr. S. Aravinda Kumar, Chief Consultant, Interventional Cardiologist with the Trichy Center of Kauvery Hospital. With close to 2 decades of experience behind him, Dr. Aravind Kumar has so far performed more than 5,000 angioplasty procedures and is among the first doctors in Trichy to do 250 plus permanent implantations and device closures. He has also done over 100 BMVs, that is balloon mitral valvotomy, which is a non-surgical way to restore blood flow, besides attending to structural heart diseases. A very warm welcome to you, Dr. Aravind Kumar.
Thank you and good morning to all.
Thank you, sir. Also joining us is our other panelist, Dr. Deep Chand Raja. He is consultant cardiologist and clinical lead of cardiac electrophysiology at Kauvery Hospital, Chennai. He's equipped with an advanced clinical training of 3 years in cardiac electrophysiology in Canberra, Australia. With MD in internal medicine from King George Medical University, Lucknow, DM cardiology from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and FNB in interventional cardiology from Madras Medical Mission, Chennai, Dr. Deep has published 42 research papers across peer-reviewed national and international journals in the field of cardiology. A very warm welcome to you, Dr. Deep. And thank you. I will now hand over the floor to both our panelists for their respective presentations on all that you need to know about heart attacks. And following the presentations, we will have a quick round of discussion on the topic and also throw open our Q&A box for questions from the audience. So the audience is please requested to first listen to the presentations carefully and then direct your questions to the specific doctor you wish to. So may I now invite you, Dr. Aravind Kumar, to give your presentation first.
Good morning all. Good morning Deep and good morning Ms. Sonu. See the next few minutes I'll be talking the changes in the scenario of heart attack management, what has happened over a period of time and what is latest in this field of heart attack management. So the heart attack management started Heart attack management first started with this mission almost 1 century back, ECG mission, which was there and which made us understand what is heart attack. And subsequently, a CAT procedure was done to understand more about the coronary artery disease. And in 1950s, after the World War II, where they understood radar, so the echocardiographic mission started, which was in 1953. And we started doing angiogram in 1958. So this is how the heart attack management started evolving over a period of time. And in 1961, we had the first coronary care unit. So until then, people were given rest, in a secluded place and given rest. That's the only way of treating a heart attack. So most of the people died because of that. And this is how the science evolved over a period of time. And this is the timeline of events which happened over the last century, and how we evolved in the management of heart attack and how we improved with time. And this is a landmark person. He did the first angioplasty in 1977, which was a game changer in the management of heart attack. So how we have managed from a coronary care unit to the procedure of angioplasty. So it took 2 decades after a coronary care unit to do an angioplasty. So that's the way science gradually evolved. So this is the reason why we can see pre-coronary care unit. This is a CCU era. I mean, pre-coronary care units, out of the 100 people, they got admitted for a heart attack, 30 people died. It means 30% mortality. So it's a very high mortality. So after invention of coronary care unit and some medications, blood thinners, it was brought down to 15 with time. And now with the invent of thrombolysis, it has come down to 6.5. And with angioplasty, it has come down to as low as 2%. So it means that out of 100 people, only 2 people die with heart attack when they reach at the right time. So that the word is very important, when they reach at the right time. So how science has evolved? So to make things simpler, by giving a blood thinners, by giving aspirin, which we commonly know. Aspirin with rest and one other blood thinner like heparin. So you can see 89 people are saved by giving a simple medication, aspirin. So that means whenever there is a heart attack, we should never delay a medication. We should always have the loading dose and come to the hospital, reach the hospital at the earliest point. So this aspirin will make out of 100 people, only 11 people are dead and 89 people are saved. The addition of another one blood thinner along with aspirin will save another 2 people. So now we are seeing how science has evolved with time. So this was happened in 1990s. Now in the 2000, you can see another medication is competing with the next clopidogrel, and it has found that it is much better than clopidogrel. And now we are using aspirin and ticagrelor in a larger extent for saving the patient. So it means, but gradually we are decreasing the number of deaths in the patient with a heart attack after a heart attack, just with the time with newer medication and more understanding of what is there. So this is another interheart study. This is one thing which for common people, everybody keeps know. See, this is the risk factor which is enlisted, and yet another Indian who compiled all the risk factors and make us understand that it is not focusing on one particular area of treatment. You need to focus on a group of risk factors and understand risk factors and make yourself comfortable, so that at some point of time you lead to decrease in the heart in the society. So this is what Salim Yusuf has demonstrated us with this analysis of the risk factors. So this is what happens over a period of time. This is a small depiction of the coronary artery. See here, the yellow part is the atherosclerotic plaque, the cholesterol plaque, and which gradually increases with time with the compiled risk factor analysis, as well as the increasing time and the accumulation of the cholesterol within the subintimal space of the coronary artery. Sometimes it ruptures and can completely occlude, causing a acute massive heart attack. The other way is it doesn't occlude completely, but incomplete, but subtotal occlusion causes more similar symptoms of heart attack. We call it an unstable angina or a non-established MI. So these are the 2 group of population which land up in the hospital with emergency. So this video just shows, see here, 20 minutes, 1 hour. See here, as the area of white increases, it means the area of dead myocardium increases. So see here, from 20 minutes, it keeps increasing, 6 hours, 8 hours, it keeps increasing. So this is the propagation of infarcted area, necrotic area is the one which causes more trouble and more trouble for the patient. So this increasing in the myocardial necrosis makes the patient uncomfortable, have a post-infarction failure, we call it as failure, and the patient can die during the heart attack or after a heart attack, in the early part of heart attack, or very late into the heart attack. So this clearly shows what is time, what is muscle. So in the time elapses, you lose loss of muscle. When the muscle is lost, patient becomes more sicker and lose life. So the clear message is you have to come very early to the hospital to get the right appropriate treatment. So you got a lot of treatment now to clear the pathway. So I told you there is a cholesterol and there is a blood clot. So to clear the pathway, we are giving aspirin and another antiplatelet blood thinning agent. But we need to give you a potent blood clearing agent, like we call it as thrombolytic agent. There is a long back, almost for 3-4 decades, we have been using streptokinase for a long time. Because of the less efficacy, we have started using newer molecule like retaplase and tenecteplase, which has got an efficacy rate around 70%. It means out of 100 people, only 75 people, the results are there to be seen. So still, in spite of all the medication, 20 people do not have the desired results, and this can cause more problem. So that's the reason why we thought of doing something more. So this is what the primary angioplasty is all about. So primary angioplasty, the patient comes with the chest pain, you immediately take them to the cath lab and see the angiogram and open the coronary artery by balloon dilating, crossing, clearing the pathway and putting a stent for anchoring the vessel so that the pathway is very much clear. So here again, the most important message is ischemic time. That time is very important. The earlier that your patient comes and the earlier the treatment occurs, the more number of myocardium is saved and the patient is saved from the problem. So time is muscle, and every minute delay causes more mortality in the later time. So which is better? Is it primary? Are the hospital doing angioplasty for fancy? No. So we are doing, there is a real comparison between angioplasty and fibrinolysis, thrombolysis. We all see that by giving angioplasty, number of deaths are decreased, number of deaths with complications are decreased, the recurrent heart attack is decreased, stroke is decreased, that hemorrhage into the brain because the medication is decreased, death, MI, everything is decreased with angioplasty. This is a gold standard treatment for any heart attack in any part of the world. But and this is what is there. See, for every 1,000 patients treated, angioplasty decreases the mortality by 20. That is 20 lives are saved and 43 recurrent heart attack is saved. So this is what we want as a hospital policy. This is what the treatment is the best treatment, and this is what we want for the society to be given. So, but unfortunately, we do not live in a conducive atmosphere where everybody has an access to the cath lab, because most of the people, the cath labs are not accessible at all point of time for all patients, because the cath lab may be at least 50-60 kilometers for most patients. So that patients cannot reach the cath lab at right time. But what we do now, because reaching for the best treatment, it takes longer time. So until then, patient cannot be having pain, and they should not be having complications with the lack of treatment. So for that, what we have is, we have combined both this treatment. We call it as pharmacoinvasive. What we do is initially give the medication, the thrombolysis medication, and refer the patient to the cath lab center. From there on, within 3 to 24 hours, we just go ahead and do an angiogram and open the coronary artery, which is completely occluded or completely occluded. So we just so that the opening is perfect and the time is not delayed. By giving a thrombolysis as well as going for an angioplasty, we are giving the perfect treatment where the patients, all patients, when they are not accessible for the current treatment, that is the best modality of treatment, angioplasty, we have the alternate bed, which is being proved right by a lot of studies in this part of the world as well. So the carrying on message is time is myocardium. The more you delay, it is going to be trouble. So whatever the medication, whatever is accessible for you, you have to do it. So when how do you want to decide on which patient to be given medication, which patient to be given primary angioplasty? If the transfer time is more than 30-40 minutes from the primary hospital to the cath lab center, then you can thrombolyze the patient and refer the patient later on after stabilization. So even in the cath lab, in our hospital where we have a lot of angioplasty happening, if there is going to be both the cath labs, we have 2 cath labs and both are occupied, we do thrombolysis and take the patient after thrombolysis into the cath lab. So we do not want any time delay for treatment. That's the ultimate bottom line. So the PCI has defined, we have got more best stents. Every over a period of time, we have got evolved into the stent technology. The drug-eluting stent has come. The drug-elution methodology has increased, and we are becoming more safer for the patient. Technology has become more safer for the patient, and the outcomes are getting much better. So not only that, we are using scientifically, we are doing the physiological study we call before doing angioplasty in stable patient. We do use imaging. The ultrasound images are there within the coronary artery, that is blood vessel within the vessel wall, and see what is happening really within the vessel wall and take a decision on it. And we use light source also to do the angioplasty so that the outcomes are much better for the patient. And we we are going to use artificial intelligence in a larger way, and robot is going to come and dominate the scenario in future. And we are going to see holographic demonstration of what is happening. Even if the patient has a complex anatomy or complexity during the procedure, the artificial intelligence is going to guide you, give you a holographic image of what is display of what is happening, so that you can have a ready-made reference, and this is going to be there in 10 years from now on. This is going to be the past and present and future, what I'm going to talk. So this is the management. Ultimately, the time is muscle is the carrying of message. How quickly you come to the hospital with the symptom, and how quickly the treatment is started. That is the most important in a heart attack. That is the most welcome for the carrying of message for the day. Thank you very much for your patient caring.
Thank you, Dr. Arvind Kumar, for that very insightful presentation. Dr. Deep, would you like to take on now?
Yeah. So is my able to see my screen now?
No.
Now?
Yeah.
Yeah, good. Thank you, Dr. Arvind, for that tremendous presentation. The way you have highlighted how time is muscle when someone gets a heart attack. There's no doubt that people, whenever they have symptoms of heart attack, should reach the hospital as quickly as possible. So I'm taking this discussion a bit further now. What happens if you come late? This is what happens. The heart muscle dies and the person ends up in a very weak heart. And this weak heart is what we call as a heart failure. Furthermore, patients with heart failure start developing symptoms like breathlessness, increase in their swelling in the legs, unable to walk, fatigue, easily getting tired, palpitations, and so much of other problems because of heart failure. This is all the consequence of a heart attack. And the doctor then would suggest some devices like an implantable cardioverter defibrillator, which can be implanted just beneath the skin, so that the patient does not get some dangerous heart rhythms. Sometimes heart attack does not give so much time for the person. That's what we call as a sudden cardiac arrest. So I remember Soma highlighting at the start of the talk that there are many of recent occurrences of sudden cardiac arrest in a lot of youngsters, 40 years, 30 years. We have a few of the celebrities that we have understood and known in public appearances, they have developed this sudden cardiac arrest. So I'm going to dwell a bit on this sudden cardiac arrest now. What is sudden cardiac arrest is when your heart stops pumping blood all of a sudden. And when the heart stops pumping blood all of a sudden, the blood does not reach the brain. And when blood does not reach the brain, the person becomes unconscious. That's when the person becomes unconscious, the person is unresponsible, they're lying on the ground, and then we will have to do something to revive the person. Otherwise, the patient or the person is dying in front of our eyes. How many sudden cardiac deaths in India? It's 6 to 8 lakh deaths every year. In fact, 10% of the total deaths in India is because of sudden cardiac arrest. The worst or the very disturbing statistic, I would say, the survival rate because of a sudden cardiac arrest is only 5%, which means 5 in 100 will survive a sudden cardiac arrest. The rest of them die on the spot. And you know what is the most important cause of this sudden cardiac arrest? It's heart attack, the block in the blood vessel, and leading to dangerous heart rhythms like ventricular tachycardia and ventricular fibrillation. So this heart attack, what Dr. Arvind had described so far, is a very important reason or the most common reason for sudden cardiac arrest. So is it possible to recognize the sudden cardiac arrest even before a person gets sudden cardiac arrest? Yes, it is possible. There are many of these people who ignore their symptoms, like acidity problems for last 1 week. They have ignored the problem of acidity or mild chest discomfort, which they thought was all normal. Sorry. So these are the problems that can occur, or palpitations. Sometimes the patients would get something called palpitations. They feel that everything is normal, and then the heartbeat, sorry, I'll have to switch that off. So these are the reasons where a person can get, or in the future, the person can develop sudden cardiac arrest. They must have been having these episodes of unconsciousness when they are, they feel the blood is of less supply to the brain, they become unconscious, they would have ignored these symptoms. And these patients, these are the persons who over the long term develop sudden cardiac arrest. What would you do when you want to develop sudden cardiac arrest? This is what the most important first aid is, to start chest compressions, what we call the cardiopulmonary resuscitation. And this is a very important first aid that people need to learn. In fact, every person in the general public needs to learn how to perform a cardiopulmonary resuscitation. This is the only thing that can save a patient who has developed a sudden cardiac arrest. There are basic life support training programs that are available, which are people can attend these basic life support training programs and then learn to do a very good cardiopulmonary resuscitation. In fact, we reach out to the schools and we train our school students to take up these training programs so that when they get into the society and they are in a position to perform these basic life support and chest pulmonary compressions. And then people also need to understand how to develop or give this timely defibrillation, which is called a shock. These defibrillation machines are nowadays available in gymnasiums, in swimming pools, in big conferences or halls and cinema theaters. But are people equipped, or do they understand how to use these defibrillator machines? There are training programs available where the doctors, the paramedics go around teaching the people, general public, how to use these basic life support and these shock machines so that people can survive or they can resuscitate a patient of sudden cardiac arrest till the point an ambulance comes and a paramedic or a doctor takes over the resuscitation. It is only by educating the public on how to perform a good basic life support that we can increase the survival rates of sudden cardiac arrest from 5% to a little or much more than 5%. Who are the patients who are at risk of these sudden cardiac arrest? If people who have family history of heart problems, who have some congenital heart problems, heart failure patients, and all adults. This is where I have to emphasize all adults more than 40 years of age with risk factors. What are these risk factors? Smokers, diabetes, hypertension, cholesterol problems, obese persons, and stress, psychosocial stress. These are the most important risk factors that can cause a sudden cardiac arrest in patients who are not aware that they have some heart problems. So I will stop here. I think I've given some introduction of what a sudden cardiac arrest is. And sorry again. So that's how we go around in understanding what sudden cardiac arrest is. So let's move on to the discussion and find out what we can do about addressing sudden cardiac arrest.
Right. Thank you, Dr. Deep. It was a very meaningful talk and interesting slides as well. So I just, from your one slide, I just pick up that you kept on saying sudden cardiac arrest. So is there also a basic difference between cardiac arrest and sudden cardiac arrest? Or it is basically heart attack and sudden cardiac arrest?
That is the difference between cardiac arrest. Whenever cardiac arrest comes, heart attack is a very common reason. Yeah. So whenever we mean sudden cardiac arrest, it means cardiac arrest. Both are the same. But then that is the difference between heart attack and sudden cardiac arrest. While I mean to say heart attack is the most common reason for sudden cardiac arrest, not all heart attacks are sudden cardiac arrest.
Right. So we have always been emphasizing on this golden hour. So that golden hour is the first 60 minutes being the most crucial time when we have to reach our patient to a cath lab, the nearest cath lab. So now, as in the background discussions, we were talking about, how to look at the problem, people who live in cities, people who live on the periphery, and people who live in deep remote areas. So cities, obvious problem is the traffic, while remote areas, obvious problem may be availability of the facility. So in such situations, what do you recommend, how to address the solution? I mean, Dr. Arvind, you could take it on first and Dr. Deep could add.
Fine.
Because this kind of load, I think, will continue to increase. I don't know how when our cities will get decongested and when the topmost facilities will reach, a wider population. So keeping those things in mind and also keeping how the incidence is increasing. So what would your point of view be on that?
Fine. See, this is a very important question to be discussed because see, the incidence keeps increasing because one, the population as such is increasing. Second thing, the way the population grows is very important because when we were younger, we were more active and we didn't have TV to watch for. Now we people have TV and we are more stressed out, and the demand for money has definitely increased with time, and it has increased the risk factor for everybody. As Dr. Deep was pointing out, there's work stress. Stress is very important, which has triggers whenever there is going to be multiple risk factors like diabetes, hypertension, dyslipidemia, and when there is going to be a work stress and lack of sleep and lack of physical activity, that triggers a endothelial erosion, or what we call that, it is a trigger for a heart attack. So this trigger for a heart attack increases with time and it decreases with the age also in the current population. So whenever we are going to have, we have seen heart attack at 50s, 60s in the Western world. Now we are seeing it at 30 and 40s in the Indian population. So that's the reason why the incidents are keeping on increasing, and we have to definitely stop it. So how do you want to stop it? So one thing is very important is prevention rather than trying to treat all these patients. So we have to educate them. So trying to do a procedure in a cath lab or putting an ICD is very easy for me and Dr. Deep. But that's not the way to go. The prevention is most educating them and making them exercise, and preventing an heart attack is most important carrying home message on any talk, given talk for a general public. So we have to educate, ensure that they are more active, they are less stressed, and they actively, they sleep properly well, and we have to find our way to work for India rather than for US, where the timing is diagonally opposite. They live and the IT people are working during night, which is not conducive. Because it's by our circadian rhythms, they have to sleep between 11 and 6. It has to be 11 and 6. So they cannot keep on working, which the hormone status completely deranges, and they land up in a diabetes, hypertension, and very early heart attack. So these are the things which we have to ensure that heart attacks are prevented. So once it has come, you have done everything to the society and you have educated them. But how do you want to prevent it? That is most important. How do you want to treat once it has come? So as you rightly point out, the facility may be there, but traffic prevents them from having the right treatment. Or the facility may not be there. So access to the facility is from a remote place is going to be there. So this is you have to have a bridge between these two. So this is the time I told. So whenever there is going to be a heart attack, I'll just simply tell you the chest pain, which they have not experienced in their lifetime. That is one point, which is predominant on the left side. It could be on the right side as well, which can radiate to the left arm, inner part of the left arm, associated with sweating, vomiting, giddiness, something like that. So if this is going to be there, please do not think as gastritis or acidity, as Dr. Pradeep was kindly pointed out. So we always tend to come late thinking that it's acidity. So this is it. Whenever you are going to experience similar type, say somebody with a pinpoint pain, it's not going to be hard. Heart is innervated by some 4 or 5 nerve system. So it means that the pain is going to be diffuse. Heaviness in the heart, or a burning sensation, or a irritation, or a pain. These are a squeezing time. These are a type of pain which most of the time if this pain occurs, you have to reach to the hospital. So once you reach the hospital, nearest hospital, do not try to reach to the cath lab center if it is going to be far up, more than 1 hour or 2 hours. Try and find a diagnosis by going to a nearby hospital and get a diagnosis, right? And once the diagnosis is there, you have to have a green corridor to come to the cath lab. If it's not possible, then you have to ensure that you give the thrombolytic medication at the point of contact. From there on, you have to prepare yourself to the cath lab center. That is within 3 to 4 hours. Even the primary medication is not working, it is failing, we can always do a rescue procedure for them so that the patient gets benefit out of it. So as we were talking about time is muscle, whenever there is going to be a delay, every minute delay is every cell, myocardial cell death is happening. So it means that in future, the patient, even if they survive it, they survive with a hardship because their heart is going to pump much lesser and they are going to have arrhythmia, they are going to have disability, they cannot carry out the normal activity what they were doing it for a long time. Their strenuous work cannot be done. So these can be prevented by having the right appropriate treatment. So the public, what is the message to the public is, so you have to aware that every patient, every hospital, every place, every center, whether city or village, they should be aware that whenever there is going to pay, they should go to the nearest hospital with facility for taking an ECG and giving the loading dose. The loading dose is a blood thinner agent and a cholesterol agent, which we give it at the time of immediate diagnosis of the chest pain. So once it is done, your job is done to begin with. After that, the definite treatment should start with either a medication or angioplasty, which the doctor concerned are very knowledgeable at all places, because Tamil Nadu is one of the high forward city place to live with as far as the health standards are concerned. So where every doctor is educated enough to understand for referring the patient for a primary angioplasty or a thrombolysis. I think I have answered your question well.
Yeah, right. Would you like to add anything, Dr. Deep?
Yeah, I would rather wanted to give more lead or show light on this to the audience, and I will ask Dr. Aravind to answer this. Dr. Aravind, can you shower more light on this thrombolytic agent? Because we do get patients coming to us asking what is this thrombolytic agent? Doctor has given some injection, and is this to dissolve something or clot? Can you shower more light on this thrombolytic agent, how important this agent is?
Oh, very good. See, this is the thrombolytic agent is the one. See, you have to have what is the coronary artery? That's basically. So coronary artery is the artery which carries blood supply to the heart. So it measures only 3 millimeters, like a ballpoint tip. So what we is projected and see is a magnified image, what we are showing in the cath lab to the public. But what is really is that it's a 3 or 4 millimeter size vessel what we handle really inside the cath lab. So this, when there is going to be a cholesterol deposition, over the cholesterol deposition, there will be a skin over the cholesterol. This skin is called the endothelium. So endothelium, after stress or some risk factor, it gets peeled away because of the stress. So once this is like any injury happening in the hand or any part of the body, the blood tries to clot and prevent it bleeding. That's all. Endothelial integrity is lost, so that the platelet, this is what the first line of defense for blood clotting, comes and closes of the healed damaged area. So that is not sufficient enough, means another clotting factor comes and sits into it. And beyond that, if it is still not able to control it, then we have a fibrin mesh. It is like a mesh sort of thing, which comes and closes. So this heaping of this platelet clotting factor and the fibrin mesh completely closes, unwantedly completely closes, because it's such a small vessel, 3 or 4 millimeters, completely closes of the artery. So we need to open it. So that's the reason why I started telling about antiplatelet, that is blood thinning agent, aspirin, clopidogrel. That's what I was talking about. So you target it to begin whenever there is going to be the first point of contact. Every time we are giving a loading dose, we give antiplatelet, aspirin or some other medication along with it, like a clopidogrel, ticagrelor, or pacemaker, depending on the necessity for the patient. And the definite treatment is one. Now it has fibrin mesh. It is a strong mesh. It doesn't open with your aspirin or anything. So we have to break open the mesh. For that, we are giving the thrombolytic agent. We are just breaking the mesh of tight clot. So we are giving the fibrinolytic or thrombolytic agent, so that the pathway is created. So the pathway, from even 1% clearance of the pathway will save the patient. But only thing is, it is not the definite treatment where there is a tendency for reocclusion in the same area. So we have to do a angioplasty. That's the reason why the patient needs to be transferred to a center of interest where cath lab facility is there. From there, the patient has to go for an angiogram and an angioplasty. Whatever the residual, the blood treatment has been given, blood thinning agent, fibrinolytic has been given. This treatment has to be supported with the definite treatment of angiography and angioplasty, so that the recurrence is not there and the patient is saved completely. And more importantly, this is as simple as that. In an agricultural land where there is going to be inadequate supply of water, all the crop dries out. So likewise, the heart muscle is inadequate with blood supply, the muscle is dead. So we have to ensure that adequate water to the land, adequate blood supply to the heart muscle. So that's the reason why we try and open the coronary artery as early as possible at the best possible time, either by giving a medication, that is a fibrinolytic, thrombolytic, as Dr. Deep was pointing about, and followed with an angioplasty.
Right. So before again we go deeper, you've already explained and said it in your slide, but one of our participants, the questions have started coming in. Anju Parik is asking you once more, which medicine you need to give to the patient at home before they're able to take the patient to the hospital?
So there is a pack of medication for loading dose, we call. Say, I keep on educating the patient, especially the teachers and the community people, where I ask them to keep a loading dose pack. So a loading dose pack includes a soluble aspirin. We call it as Dispirin. It comes in a 325 milligram dosage tablet. And we got clopidogrel, that is much more safer because ticagrelor, other antiplatelet agents are the one which use based on the discretion of the physician. For home preparation, domiciliary preparation, it is clopidogrel, 4 tablets, each 75 milligram will be there, 4 tablets, and atorvastatin is another one statin, which we give 40 or 80 milligram depending on the physician discretion. But most of the time we have a pack of 6, which we encourage in our hospital also. There is a pack of 6 with 1 tablet of Dispirin, 4 tablets of clopidogrel, and 1 tablet of atorvastatin, which is being encouraged and which comes with a pack and we encourage in our hospital to the patient attenders, so that whenever there is a near kith or kin of the family members, they have to reach out to this tablet and take it. So not every time with the chest pain they have to see. That's what I described the chest pain to you, so that they have to be the appropriate medication. So whenever there is a chest pain, this medication has to be given as a first aid, and the definite diagnosis has to be made in the hospital and appropriate treatment to be started.
Is this golden hour for stroke? Somebody, Sugita wants to know the golden hour for stroke and golden hour for MI. Is it the same or is there any variation?
See, the golden hour is very simple. The first hour, that is before any damage occurs. See, it is an insult to the heart. Heart attack means heart attack, a heart muscle, or a stroke means it is to the brain. So before it irreversibly loses function, because when there is going to be a blockade into any part of the body, the cell will utilize the oxygen within the whatever is available at that point of time until it is restored. So when it is not restored, it loses all the oxygen and the glucose, whatever there is in the cell, and it dies. So before the cell dies, we have to reach. So this is the treatment for golden. This is what we tell it as golden hour. This is the time where the cell is dying. It is crying. That is the cry we experience at pain. So this cry of pain should be there before the patient starts. So that this within the 1 hour, that is most important. Within 1 hour is the time where we don't lose much of myocardium. The earlier you come, more quickly the myocardium is salvage happens and the patient gets better. So that's the concept of golden hour. It is the same as any part of the body. When there's going to be occlusion anywhere, any peripheral, any blood vessel to the lower limb or upper limb or to the lung, we call it as pulmonary embolism. To the brain, we call it as stroke. In the heart, we call it as heart attack. So it is the same. You have to reach to the hospital for salvaging the myocardial cell and whatever the cell is corresponding.
Yes, exactly. The nerve cells are more sensitive to this ischemia again. So as Dr. Aravind was telling, you'll have to reach the hospital in a golden hour, be it a stroke or a heart attack, no matter. But then chances to salvage the stroke are very less beyond 3 hours. You cannot salvage a stroke beyond 3 hours, or maybe for certain patients, 4.5 hours. But there are some chances to salvage the heart muscle up till 8-9 hours. But then the chances of heart failure also increases. So those are the golden, what we mean by golden hours for stroke and heart attack.
So Narmada is asking, what should a person do if he or she is alone and develops chest pain or heart attack? She's worried about her 60-year-old father, who's perhaps many times alone at home. So what kind of precautions should we take?
So they need to have a real check, there's a smartphone or something they need to have to pick up what is there. That is one thing which modern technology has given us. And they have to pray that it should not come. That's the only option, because they need to go to the hospital. No treatment cannot be done for a heart attack at home. That's for sure. So they have to reach the hospital for a diagnosis and for treatment. What they can do is they can have the loading dose, which can possibly start the treatment at this, wherever the place they are in. But they have to make a diagnosis. So this the smartphones now, our digital technology has improved a lot, where just connecting them to the chest leads, whatever way the technology is demonstrating to you, Okay, it can give you a rough clue of what is happening, and it sends an image to image and as well as a diagnosis to the corresponding number which they have been tuned to and connected to. So that has given a telemonitoring of what is happening in elsewhere. People living in US can monitor their parents in India. This is what the common occurrence is the IT professional living in US and the elderly parents where they live alone. So this is what technology has demonstrated, and all the newer phones have come with this type of gadgets. But it cannot be taken for granted that everything is going to work. So only thing, if the patient needs to come to the hospital, that's the most important part. So they have to have a local contact. That is most important. They have to find a nearby community society where people should be there willing to help them out at the point of crisis. They come to their rescue. That's the most important part. So because they have to live in a gated community of helping each other. And if there is going to be that sort of a association is there, then it becomes an easier target. And if they are remaining in the house for treatment until help comes, that's going to be difficult task to save us in the future. As Dr. Deep was clearly pointing out, we can, heart attack at least we can save up to salvage, because we have got 3 coronary arteries where at some point of time they will collateralize. That will, the other artery will try and support the other. Whereas in brain, it's going to be tough. When there's going to be stroke, after 3 hours or so, your loss of function is going to be permanent throughout your life. So that is most important, and heart attack as well. You have to reach the hospital.
So since we are talking about precautions, somebody wants to know that if somebody is already on medication following heart attack, so is it possible to avoid another attack, or is there any means to visualize or find out, what is the condition and if the person is going to get another attack? Is there any such?
Fine. See, this is one thing which we have to understand. We are never gods. That is most important. Carrying a message is very important. We are not gods. So we are only a mere mortal like you, and we are trying to give you, help you, educate you about the disease, and try to make you live with comfort and less morbidity and mortality. This is what we try to do. So disease is a progression. Atherosclerosis, that is the blockade in the vessel. Now we say the moment the child is born and cries, it means that the atherosclerosis started. That's the reason the child is crying. That's what funnily we keep calling about atherosclerosis. It means that it starts from birth. So it is a progressive disease. It's not a disease which is there. And people are getting heart attack at 40 or 50. It means that they have a tendency to have a heart attack throughout their life. So nobody is going to get it at 40, 50 without reason. So they have a tendency for having a heart attack. There could be a genetic predisposition to be there. Their lifestyle may be such a way that they will have it. So until they change their tendency or try to modify it, it's not going to be possible. So what we are doing in angioplasty or thrombolysis, we are trying to give a cure at that point of time to at that point of disease only. So we are not going to give them a permanent remedy or giving a guarantee that it's never going to happen at all. So it means that we have to understand the disease, prevent the disease, modify the risk factor, prevent the disease. So if always you're doing completely opening the coronary artery, that is the angioplasty is essential, or a bypass surgery is essential. After that, we have to give lifelong medication. There is the medication which Dr. Deep can explain on it. So where if preventing a heart failure is, there are huge battery of medication is there. Dr. Deep is an expert on it. So that medication can be given for the particular patient so that the heart failure is prevented. On top of it, there is going to be a diet. So diet is going to carry a very, very good part in your management of heart attack, recurrent heart attack. And there is going to be a physical activity. So minimum for every given patient, we gradually try to increase the heart walking capability, and we try to make them exercise for at least 3 kilometers for 40 minutes. Such way, we are giving a protocol for individual patients so that we target everything: medication, good angioplasty or a bypass surgery, and exercise, and diet. So all three, everything should fall together to have a prevention, and we have to pray God that it should not happen again.
Dr. Deep, you had briefly touched upon the role of defibrillators also in your presentation. So does it really prevent a sudden cardiac arrest in patients who have survived a heart attack?
Yes, there are ways that doctor can find out who are the patients who are more risk of a sudden cardiac arrest after having a heart attack. Who are survivors of heart attack, for example, with very severe heart failure, or who have had this, who have survived a sudden cardiac arrest, or something, they have some dangerous heart rhythms like ventricular tachycardias and things. And if In these patients, the doctors understand the risk of having a sudden cardiac death. And in those patients, they advise a defibrillator would help prevent a sudden cardiac death in these patients. So there are ways the doctor can find out all these things.
Right. And so to add on, like how to, Vaishali is asking, how to deal with a heart attack after few years of stent implantation.
So once a person, I think Dr. Arvind has given the introduction of how you need to manage a person with a heart attack. Medications, there are 4 pillars, I would say. Medications, diet is number 1, physical activity, change in the risk factors, medication. So all of these. So all of these or multiple roles of each of these in combination will help to bring down the risk of having a further heart attack. Medications, and again, are very important. Anyone who has had a stent would be put on blood thinners, and no one should ever stop these blood thinners unless the doctor has advised for some reason or for some XYZ reason. Unless the doctor has advised, the patients should not stop the blood thinners for any reason. In addition to these blood thinners, there are very important medications in heart attack management so that the patient does not develop another heart attack. A few of those are like beta blockers, heart failure medications. These are the medications that people need to keep in mind to continuously take. And that's something, again, a very important medication called a cholesterol lowering medication, a statin medication, which is, again, a very important medication in the list of the heart failure and the heart attack medications that a doctor would prescribe.
So when even in patients who have pacemakers implanted, is it true that they cannot fly, they cannot undergo any air journey because of some chip in that device?
No, that's absolutely false. Yeah, because you asked the question, I have a pacemaker right in front of me, a small, it's a small metal or a small battery, I would say, which is placed under the skin. The pacemakers have evolved so much over the years. The filters of the mechanism, the filter mechanism placed within the pacemakers has evolved so much. So it does not affect anyone's normal functioning at all. The only precaution that we give to patients who have had pacemakers is keep their smartphones at least half a full scale, which means at least 15 centimeters away from their pacemakers. That's the only precaution that we give to the patients. Otherwise, they're absolutely free to carry on their daily activities as like any other individual.
So another related little morbid question, God forbid if a person who has pacemaker passes away. So is it true that they have to remove it before the rites are carried out?
Yeah, Dr. Aravind, you would have faced definitely a lot of these patients, yeah? So what would you do if a pacemaker patient has expired? And how will you go around in getting the pacemaker pulse generator explant? And what will be your plan of action?
Yeah.
A patient who has had a pacemaker, it expires, what would you do?
Oh, fine. This is a question to me. See, this is whenever the patient dies with a pacemaker, see, nothing. Pacemaker is no big deal. The only is the lithium iodide battery which is there. So whenever there is going to be lithium iodide battery, whenever you are going to a crematorium, like any other battery, it is tend to explode. It is not going to cause a huge explosion. It is a small battery, very small, as Deep was fine. It's going to. But only thing, there are 2 things. One is social, another one is financial. So the social aspect is, I don't want to remove the pacemaker and allow the patient to get cremated or crematorium or either to be buried or to be burnt. So when there is going to be buried, there is nothing going to happen because there is no explosion or anything. And inside the government electric crematorium, nothing is there. You are not even going to hear the noise of the pacemaker blast. And that is going to be very, very small as a top sound. That's all, not more than that. So, but only thing, whenever there is going to be a pacemaker implanted for 3 months or 1 year, and the battery life is there for remaining 9 years or something like that. So this is the point where we have to, as a society, we have to take care, educate them to get the pacemaker out, and which can be used for, after appropriate sterilization, can be reused for poor people, where the pacemaker cost is completely cut off and taken care. This, I believe, Dr. Deep will have a good social networking to do it, where they, as a policy, whenever there is going to be a pacemaker implanted and the patient dies within less than a year, we try to explant the pacemaker and get it appropriate sterilization and get it done for a poor patient so that they don't need to have need to pay the money for it. That's we do it as a social charity work for the people which we are doing it. And Western world, the pacemakers are taken back to India and they are doing it as a charity work also, explanted pacemaker we call.
Okay, that's a good point. So, going back on the thrombolysis point, Doctor, Suresh Kumar Raja wants to know whether while shifting a patient, thrombolysis can be done in an ambulance, and is it being practiced in India?
Oh, definitely. See, this is what the Denmark is the one country which was the pioneer in doing it, and it has come to practice everywhere. So there are two. Where I was during my presentation, I was telling about one thrombolytic agent which was there for 4 decades, and it has to be given for 4 hours, and it was 1 hour, and it requires a lot of monitoring in the hospital because there are a lot of blood pressure monitoring variation is going to happen. So that's not the best way to give a thrombolytic agent whenever there is going to be a planning or travel. Now the newer agents are very smart. One agent called tenecteplase, where it needs to be given within 5 seconds. So immediately you just diagnose 5 seconds, one shot, less than 60 minutes, you are going to see an opening of the coronary artery. So that is the way. So whenever that is going to be, you just take a diagnosis. So in Western world, it is there simple. The ECG goes to the primary consulting cardiologist over there in the tertiary care center. They'll look at the ECG, alert the ambulance team. The ambulance team go with the medication, give an injection of this medicine, and they take them to the ambulance and come to the cath lab and open their block, whichever is there, residual is there. It is there. So that's a good way of doing it. Further, the tenecteplase is much costlier than the earlier medication which we are doing it. So if it is possible, the only thing is more and more number of people are using it, the cost is going to come down, with the production cost is going to come down. So that's one way of getting the cost down as well. So that's easier to do it and easier to transport also.
Dr. Deep, could you please repeat the cholesterol lowering drugs for a heart patient?
Yes. So as I was trying to answer by typing out my answers to a few of the people who are asking questions, there was one important question that was coming up with regarding to cholesterol. What are these cholesterol lowering medicines? Are they meant to prevent heart attacks? It's a very valid and valuable question. Over the years, one drug which has strengthened in its importance is this cholesterol lowering medication. There are a few medications which have fallen out of favor as well, but there's one medication which has stood the test of time, which is this cholesterol lowering medication. This cholesterol lowering medication is what we call a statin. It's called a statin. A statin or there are various statins, and atorvastatin or rosuvastatin are the commonly used statins in the country, but then there are many other statins as well. So these statin medications are the most important medications after a heart attack, not only after a heart attack, also in people who have risk factors like diabetes, who are smokers, who have a certain level of a risk profile. These are the patients who need to be on statins to prevent a heart attack and to prevent a stroke from affecting them. So this is both a preventive medicine as well as a treatment medicine. This is a medication in both the ways, and this is the most important medication nowadays in the management and in the prevention of a heart attack.
What is silent heart attack?
Oh, this is a nice question. See, I was describing the pain, how nature of pain and where it happens, and this is what so whenever the pain you are not able to perceive because of the numbing of the nerves due to diabetes or elderly age, you will not perceive the pain. But the heart attack happens. This is called silent heart attack. So that you should be aware of. All diabetologists also make them aware, and whenever the diabetic patient we see for other reasons like hypertension, something like that, we always make them aware of these symptoms. So it may not be the same as rest of the population, but they really have a pain which is very much unbearable, and this is not the pain. So they'll have some sort of a dizziness, or we call syncope. They can faint and fall, and they come with a heart attack, or they'll have giddiness, vomiting, dyspepsia, something like that, which is not the normal way of presentation. They can be presenting like that. And the typical pain may not be there. They may experience pain only in the arm. So something like that happens with the diabetic population. So which make them do not understand they have a heart attack. This is the reason why we call it a silent heart attack. So that is more dangerous. So whenever they are not, see, a patient sweats profusely after taking a food, after 1 hour of taking food, it means the patient glucose has not come down in diabetic population. It means something abnormal has happened. The profuse sweating, which make them drenched with all the clothes drenched with sweat. So it means that you are likely to have a heart attack, which they are not perceiving pain. So it's not hypovolemic. Giving a sugar water is not going to be the treatment. Reaching the hospital is most important. This is not the one they are likely to experience after taking food. So this is what the alternate ways of presentation. This is what we call the silent heart attack.
Doctor, is there a way also to transport a patient after he or she complains of these symptoms, which could lead to cardiac arrest, or maybe the patient is having a heart attack? Like, because these days, even in small towns and all, more than the ambulances being able to reach the spot, a lot of bike ambulances are running in a lot of towns and cities. So is it advisable to, take the patient on a bike ambulance? I mean, is there any way of transporting? Do we have to take care of that also?
The bike ambulance is not the best for any heart attack. So that is not the way to go, because the patient needs to lie down. They have to see, they need to be less anxious. They may need to make comfortable while travel. That's the most important part to save a patient. So bike ambulance is they visualize everything around, and the way the bike is going to be rode at fastest pace, they'll get another heart attack on the way. So that's not the best of it. So best is to have an ambulance with the ICU capability, that is monitoring, and a defibrillator should be attached, which Dr. Deep was pointing out. A defibrillator with and the paramedics or so nurse who is going to accompany them should have a knowledge of how to deliver the shock in this patient, because the initial 1 hour or 2 hours, the muscle is going to cry and it is going to give a lot of rhythm disturbance, and the abnormal electric activity will be the cause of death in most patients. So this type of patient, they need to be prepared for a cardioversion or a defibrillation. So this need to be kept in mind, and we need to have an ambulance rather than a bike ambulance.
Okay, and then if many times even ambulance numbers don't respond on time or as fast as we want them to. So in that case, suppose somebody has a hospital nearby, can a patient be taken in their own vehicle?
If there is going to be delay in getting an ambulance, which normally a lot of patients, when we call our hospital emergency for assistance, we always weigh the balance between two. What is the benefit and risk? So when you send an ambulance to them and getting back to the patient, it takes a longer time. So at the same time, we find the patient is able to get into a car immediately, and we are going to take a risk. But the same risk is there when the patient is lying in the home. So when the patient is lying in the home without treatment, same risk again. It is unfortunate, it has happened in the car, that's all. So only thing, the travel to and fro time for the ambulance from our hospital to that particular place is going to take time. Means I encourage them to take them. Only thing, I educate them regarding the symptoms and on the way how to manage things. So I just ask them to give a loading dose and start from there and reach the nearest hospital, not to me. I do not insist on coming to me at all. I want the diagnosis to be made. I want the patient to be safe on some hospital of interest where they are capable of managing the patient. So reach the nearby hospital, whatever may be the hospital. Reach the nearby hospital, you are secure. From there on, the doctor will take care, give the best treatment, and then they may be shifted to the necessary hospital of interest.
Right. So again, going back to one little repetitive thing, when Dr. Siva Vignesh is saying, in a scenario where the ECG machine is not portable and unavailable, in that case, for an undifferentiated chest pain, can sublingual nitroglycerin crushed aspirin be given?
Oh, definitely. See, whenever I insist on few points in my talk always. When the pain is typical, when the educated, the people you are using sublingual nitrates will always be a previous coronary artery patient. So they would have experienced the chest pain earlier, and they know the similar type of pain is coming. So they can use the sublingual nitrates as advised. So they should never stand and use nitrates. That is one point. They should never lie flat and use nitrate. Two things which they have to sit comfortably in a easy chair, something like that, and use nitrate. That is the best way to prevent a hypotension after a nitrate. So the nitrate should be used in patients already having a coronary artery disease, and they know the extent of disease, and they have had the symptoms earlier, and the symptom is recurrently coming. They need to get rid of the symptom. They are giving these nitrates. Whereas aspirin, see, you know that any medication, unwanted, untimely medication is going to be dangerous. So we cannot keep on giving aspirin for every patient. So when there is a typical symptoms are there, with the background history of diabetes, hypertension, say some 55-year-old with a diabetes, hypertension, stress, lack of sleep, previous night stress, something like that, and comes with some chest pain which he has not experienced, then he needs aspirin. The same patient, okay, after a strenuous activity, I have a pain and pointing to one finger, and otherwise I'm comfortable. I went for work, I went for shopping, I went for the morning work. Should I have aspirin? They should not have, because that's not the pain. They are not likely to have a cardiac pain. So the appropriate patient should be there. It is more about educating. Time and again, lot of webinar and seminars should take place to educate them, because the public should understand what patient needs this medication.
So, how to distinguish between muscular pain and pain of cardiac origin? Mr. Bosco Emmanuel wants to know.
No, very simple. This is a simple question. Whenever there is going to be a muscle, I am going to lift my hand. See the point? So whenever I am lifting the hand, there is going to be pain while lifting. It is not going to be front of the chest. It is also going to be back. So if it is going to be the front and back, more likely to have a muscular pain, because the movement of muscle and bone is causing the pain. So nobody can touch the heart. Heart is in a case called pericardium, which is well protected and well anchored. It doesn't move. If you and you jump around, it doesn't move. So it is well protected. It is encased and kept preserved within the thoracic cavity. So your chest thumping, ordinary thumping, or your pushing and touching is not going to give any pain at all to the heart. So muscular pain, it means that muscle and joint or bone is going to get involved. So you just press hard, you'll have a pain. As simple as that. This is going to be a muscle pain, which usually gets localized after a strenuous activity or some muscle hematoma, something like that. So you just press hard, you have a pain. You move your hand, you have a pain. This is going to be the pain, which heart pain will never be like this. It is deep-seated. Heart is innervated by some nerves, and that nerve will cause a pain. That the pain is totally going to be different from what you're there. You cannot touch and make a difference.
So sorbitrate can be given as a preventive to be kept.
No, for muscular pain, sorbitrate is not going to be useful. But unfortunately, sorbitrate has got other action, like for a gastritis or a cholecystitis. It can relieve the spasm in the bile duct as well as in the lower esophageal spasm. So that that pain also can get relieved with your sublingual sorbitrate. That can get you into a cardiology rather than your diagnosis. So always, in order taking sorbitrate is not the solution. Going to a doctor, getting their guidance before using any medication, self-medication is most important. So there are a lot of information in the WhatsApp and in all the papers and everything it is coming in. So we have information, it's a raw information. But what we require is a guidance from a doctor. The raw information cannot be fixed. It's a fixed for a whole population, not for one particular patient. So it is generally given by the experts, give a general opinion about everything, but not for a particular patient. So every patient have to have the knowledge, but go to a doctor, get their opinion before doing it.
Right. Dr. Deep, could you once again just elaborate a little bit on the differentiation between gastric pain, which is often, and you was mentioning, people for 1 week they keep sitting thinking I have some gastric issues, and they could be ignoring some other bigger issues. So if you could just
my best and any doctor's best advice would be, if at all you have acidity-like complaints, let that distinction between a gastric pain and a heart pain be done by the doctor. Even there are so many doctors who are fooled by what they think is acidity, and finally in 2 or 3 days time they would find out that they have been undergoing a heart attack or something like that, or ischemia because of a heart attack. So let this be handed over to a doctor who evaluates with an electrocardiogram and ECG, some certain blood tests like troponin levels, and then make the distinction, especially in patients with diabetes and patients more than 60 years of age, when they are these are the persons who are likely to have more of acidity-like symptoms, which could in fact mimic a heart attack. Having said this, a rough distinguishing feature, anything aggravated by food or relieved by food is more often related to the acidity or a thing. Anything unrelated to the food could be because of the heart pain. But then again, I put a word of caution here. This distinction between an acidity and a heart pain needs to be made by a doctor with the appropriate test.
Right. There should be no delay also in that case. Okay. And then again, a little bit of repetitive, and maybe you need to emphasize on the preventive thing, because somebody is mentioning that in his family, they have a lot of people with a history of heart attacks or even cardiac arrest. So maybe he's safe till now and is anxious to know, can he do anything to prevent himself from getting a heart attack?
See, heart attack can be prevented. Definitely, there is no doubt. At least the virulence of the heart attack can be decreased by the way we live. See, the way we live is very important. So we have to sleep, at least continuous sleep for 7 hours a day. We have to walk at least 45 minutes a day, and we have to have a healthy diet. So these three all components will help you in preventing. So heart attack, definitely there is no doubt that there is genetic predominance is always there. When the parents are having a heart attack, we call it as anticipation. So the next generation will have at least 10 years prior to what the parents had. It means that 60 the parent is having, with the amount of stress and the anticipation genetic predominance, we likely to have 50. So what we need to do at 40, why I am worried, whether I have a heart attack. Definitely, you are likely to have, but only thing is, you by all your smart activities by prevention, we can always postpone the occurrence. And even if it occurs, we are in a position to bear it and we survive the heart attack. So two things, postponing and surviving. If the destiny is there to have a heart attack, we'll have it, but only thing we can withstand it. That's the way to prevent it and go ahead.
Right. So we're almost nearing the end of the time of our session. So one last kind of a wrap-up question to both of you doctors. Like, what do you think as practitioners, what is the most worrisome thing for you today, in your field? Like you feel that people are not taking adequate precautionary measures, or there's not adequate, say, emergency backup facilities. What is it that worries you the most as far as, cardiology cases or the rising incidents are concerned?
Yeah, I have my answer. I will leave Dr. Arvind to give his answer, and then I'll give my answer. What is it most worrying to you, Dr. Arvind, in the context of heart attack nowadays?
See, the lack of awareness is one which I'm always worried about, because every time the neighbor has a heart attack, they diagnose it properly. When they have a heart attack, they come with a statement of acidity. So the denial of the disease, that is most worrying for me, and the lack of awareness to go to the hospital at the appropriate time, appropriate hospital bed. So the context of family hospital, family physician is because of the evolution of super specialty care, the family physician care has lost. So that family physician touch is lost means that whenever there is going to be a minor problem, you call up the doctor and take a diagnosis. It's not there now. So this is what is lost in the last 1 or 2 decades with the evolution of super specialty care, where every organ is taken care by one another doctor, and the other doctor doesn't know what's happening in another organ. So this is what has happened. This is the worrisome for me, because the family physician concept should come back. People should be encouraged to go to the family physician, take a decision of what is heart attack. Do not read whatever there in the digital market, digital field, where you will have everything what is there. Every doctor now extempores their way of statement, and everybody has the access of the statement. But having known that the raw data is not going to help you, refining the data and make yourself understand is most important. So your scientific knowledge is never going to be easier for your patient care. So coming to the hospital, reaching the hospital is the most important. This delay is what causes most suffering in maybe a heart attack or stroke or whatever the emergency is happening. The delay in getting treatment because of the access to the facility, social media, which is the most worrying at this point of time for me.
Yeah, and for me, it is the youngsters, the number of youngsters less than 40 years who are getting heart attacks and sudden cardiac arrest, especially of late. It is directly related to the bad diet, be it the chicken biryani they're thriving on, or the chicken burgers they are thriving on, or whatever lifestyle changes, the sedentary lifestyle and things. For me, this is very worrying, because this is a working age group. And if they get a heart attack and a heart failure, it decreases the productivity of not only the person, the family, the society, and it is not good for the country if a working age group like an youngster lands up in heart failure, sitting up in home rest of the life. Be it heart attack or be it stroke, it's the same. So for me, this is a worrying factor.
I know both are very valuable points. I mean, eating habits of youths, and that point about, when it strikes a neighbor, we are able to diagnose, but when it strikes us ourselves, we are not able to. We are in a state of denial. A lot of participants have appreciated your presentation, and they're asking for access to the slides that you kind of presented. So I hope the Hindu team would be able to help them out. And let me take this opportunity to thank both of you doctors for sparing your valuable time and really sharing some very, very relevant and important points about heart attack management, and also all our participants who filled us up with very useful and relevant questions, because the answers were packed with information. So I once again thank you all for joining this edition of the Hindu Wellness Series brought to you by Kauvery Hospital. Thank you.
Thank you.